Welcome, everybody, to the Community Technical Assistance Center webinar on Aligning with Healthcare Reform, the Role of Cultural Competence at the Program Level. We're very excited to have with us today Carol Siegel, Director of the Nathan Klein Institute Center of Excellence in Culturally Competent Mental Health, and Jennifer Hernandez, the Administrative Director at the Center as well. Lenora Reed-Rose unfortunately couldn't be with us today. She did present with us at the last webinar that we did earlier in the month on cultural competency at an organizational level. Before we get started, I just wanted to orient folks to the webinar system, especially if this is the first time you're on with us. We have quite a few people that will be coming on. So everybody is currently muted. If you would like to communicate with us, you can use the chat box. The chat box is on the bottom right. And if you don't happen to see that chat box, there's a little bubble at the top that says chat. Make sure you press that. That way the box will pop up. If you want to send any comments or feedback, or sometimes we'll be asking you to participate in either a poll or to answer a question, just type in your responses there and make sure where it says send to that you hit send to all panelists on the drop-down. We will have an opportunity for questions and answers towards the end of today's webinar. It is a 1-hour webinar, and so we'll probably end about 10 minutes early just to give everybody a chance to answer, to raise questions, to have a conversation with our wonderful presenters today. I'm going to briefly mention the CEU process. I know many of you are probably really interested in hearing how to get the CEU credit today after viewing the webinar. So we're very lucky to have collaborated with the NYU Silver School of Social Work, a licensed CEU provider for social workers in the state. All attendees will get an email from us after the webinar, so probably within the next day or so, you'll get an email to those who attended the full webinar. So you do have to attend the full webinar to be eligible. And that email will have a link that allows you to go to the NYU Silver School CEU processing page where you'll register your name. There is a nominal $15 processing fee that is required by the school in order to process the CEU credit. You will then be able to complete a knowledge test around the webinar information, and then you should be able to receive your certificate from the school within 10 business days. So I'll go over this again towards the end of the webinar in case we've missed some folks. And just as a reminder, though, additional information on how to register you'll receive in an email probably tomorrow at a certain point. Thank you, everybody, for joining us today. We're very excited to be able to do this two-part series on incorporating principles of cultural competence throughout your organization. And I'm just going to hand off currently now to Dr. Carol Siegel to get us started. Thank you so much, Carol and Jennifer, for joining us today.
Thank you very much, Lydia. Next slide, please. We're really pleased to have been invited by the CTAC to present to you today some of the work that we're doing at our center, which, as by its title you can see, is totally devoted to the development of cultural competency products and basically within a research framework. So today we want to tell you about one of our products, and we want to embed it in a context. We want to tell you about what we call the program-level cultural competency assessment scale. But in order to ground it and have it come to life for you, we want to begin with giving you an overview of CC means cultural competency, an overview of cultural competency because from our center's perspective, we view it as a system-wide intervention. And as a system-wide intervention, it has applicabilities at the multiple levels of the system. And then we want to help you understand how we discovered the sort of the dimensions of the instrument that you will be hearing about later on in the talk. So we're going to describe what we call our 3-site study. I'll turn the talk over to Jennifer later in about a half hour, and we'll walk you through the assessment scale as much as we can and motivate it for you. So let's begin with the overview. Next slide, please. So we begin with the definition of cultural competency. There are hundreds of them floating around. The one that we like to hook onto is that it's a multi-pronged approach that enables a healthcare system to engage and provide high-quality care to clients who have diverse values, beliefs, and behaviors. And we take a broad view of diversity. It's not just racial ethnic groups. It could be the LGBT population. It could be rural communities, and so on. Next slide, please. Next slide, please. Now, as I said, cultural competency needs to be viewed as a system-wide intervention. In the last talk given by Lenora Reed-Rose and Gary Hoagland, you heard about our view of cultural competency on the organizational level of either a mental health system or an agency, but there are organizational level policies and procedures that can be put into place. You heard a lot about that. But let's go down the chain. Under organizations are the programs, and I have that in red because that's the subject of today's talk, and there are lots of things that we can do to make our programs more culturally competent, and we'll go into the details on that, which is basically the instrument. But I want to move down the chain because there may be subsequent talks where we could talk about how to make caregivers culturally competent. That's sort of on a personal caregiving level. And then we're highly involved currently with not making consumers culturally competent. That doesn't really make sense, but activating them to represent themselves culturally and be advocates for their cultural views. Next slide, please. So let's just clarify what we mean by a program. A program sits within an agency, and it's some kind of bundle of services provided within some kind of framework of a modality of care. So here are some examples. For example, the PROS program, an inpatient treatment unit within a hospital, Parachute, maybe some of you know about that, respite centers, and so on. Next slide. Next slide, please. So why is cultural competency, why does it have currency to healthcare reform? Because whatever we do at whatever level, if it's cultural competency activities, they are essential to meeting the triple aims of healthcare reform. And these triple aims are filtering through to all the models and programs that you might be finding that you have to sign up with, become part of. So essential to meeting the triple aims, cultural competency improves population health, it elevates the quality of care, and we can argue that it even reduces healthcare costs because dollars that are spent in cultural competency activities, because it does cost money to do these activities, will be offset by benefits of more effective care. And when dollars are being attached to value rather than quantity, there is benefit in the cultural competency activities. Next slide, please. Now, cultural competency, this slide really wants to depict for you that it really, the bottom line is we want to improve client outcomes. We want to improve client outcomes so that there are no obvious disparities that the healthcare system can address. We could have another webinar on disparities because they're impacted by many things, but certainly they're impacted by how a healthcare system responds. So this little chain here, if you follow the arrows of the chain, you know, you start with the organization's policies and procedures. You heard about that at the last webinar, and they trickle down to what you're able to do with your staff, how you're able to organize your clinical teams. These clinical teams work within a milieu, and that milieu is where the programs sit, in some milieu, and that milieu works with clinical tools, it has certain services, and then they're the care deliverers who deliver the care, and that then results in the outcomes. So in all these boxes, we can really talk about where cultural competency should play a role. Today, we're going to talk about the red, which is the program, its atmosphere, how it does staff coordination, what are the tools a program can use to promote cultural competency, and so on. So no details here, but this is the big picture of how cultural competency from the top down trickles to the patient level, consumer level. Next slide, please. Lydia?
Hi, Carol. Thank you so much. So there is a poll question that just popped up on your right-hand side, and so we wanted to see kind of where everybody is on some of these cultural competency principles. So do you think that your programs are infused with the principles of cultural competence? So are the programs at your organization currently incorporating principles that you believe align with this cultural competence perspective? So the answer is yes, no, or not sure. So we really would like invite everybody to participate, click what your response is, and there's a little submit button at the bottom right that then sends the information to us. So it'll just take a couple seconds, and then we'll see the result. Okay, so I think we'll see the results momentarily. So the question is, how many of you believe that your programs are infused with principles of cultural competence? Yes, we have them in our programs, or we infuse them. No, we don't, or not sure. So many of you were able to answer, and it seems like the majority of you, so thank you so much for participating. The majority of you are saying that you believe that these principles are infused. Some of you are no, not at all, and a few not sure. So, and I know a few probably didn't get a chance to answer quick enough. So thank you so much for participating, but I think that helps us to kind of think through what, a question that I would have, and feel free to chat this in, is how are you incorporating those principles, and which principles specifically? So you can use that chat box on the right-hand side and just start chatting in some things that how you're actually incorporating some of those principles. That would be helpful for us to know. In the meantime, Carol, I think you were going to talk a little bit about the elements of the program level cultural competency.
I just want to respond to the poll a little bit.
Sure, absolutely.
52 of the 165 did not answer. I can understand that, because there probably is some uncertainty as to exactly what is an infusion of cultural competency. So especially when we're in a learning mode as to what the activities might be. So I'm not too surprised to see such a large number there. But anyway, because when we started our work, we weren't 100% sure of what activities were. We could speculate, and a lot of them really focused on clinical cultural competency, neglecting the other facets of cultural competency that need to be infused in an agency and its programs. Okay, so we mounted a study. We said, well, we don't really know either what these elements are, and we ought to, as good researchers, do some kind of ethnographic field work to discover what they are. So we mounted a study of, I'm going to ask you to flip to the next slide and flip back to this, flip to the next slide. And the next slide, please, if you don't mind. The next slide. The next slide. So we would have loved to base our study on what's called an evidence-based program that had that we knew was culturally competent and that had evidence that it really improved outcomes. Unfortunately, there's very little research on evidence-based culturally competent programs. But what we found is that there were many programs in the community, what we call community-defined evidence-based programs, that were developed for cultural groups by persons from cultural groups, grassroots developed, and they had evidence in that they were well received in their communities, had longevity, and were community supported. Now let's go back 2 slides, please. So we chose 3 such programs, and we were going to document the cultural features of what we call these well-received programs and look at them and determine cross-cutting themes of what it means to be culturally responsive on the program level. Next slide, please. We chose with community persons, community stakeholders, we chose 3 programs that are very different in who they cover and what they're doing. One was almost like a prevention program. It was called PASS, and I'm going to talk a little bit about each of these. It was for youth of color, and it's basically an empowerment program. Another was a Chinese Day treatment program, a predecessor to PROS. I know these programs have moved over into PROS-like frameworks, but this was before PROS. And we looked at the Latino inpatient unit at Bellevue. Now, by the way, there is available a video on our results, and that can be accessed at our website, but more about that later. Next slide, please. We did this one. Next slide. Okay, so PASS is the youth program, Prevention, Access, Self-Empowerment, and Support, and I've listed the names of the people who developed this program, and its goal was to improve really youth outcomes in the areas of importance to them, which is psychosocial, educational, community, and particularly getting along with their families. And it took place basically in hotels. So what did we observe? We observed that the program was able to establish a very comfortable environment for the kids. It established trust, and it used a language that was the youth language as well as a language of empowerment, which they embraced. And very critical to the program was its use of adults and peer role mentors who act to show the kids that there was a place for them to go, both as adults and currently even in their youth situation. Next slide, please. Next slide, please. Can I have the next slide, please?
Hi, Carol. So the slides are changing. So let us know, and please chat in for some reason if folks are not able to see the slides changing. I believe we're up to Bellevue Latino Treatment Program.
But my screen just has PASS.
Yeah, okay. So let's give that sometimes there's a little bit of delay, so my apologies to everybody. Sometimes there's a little bit of delay in just moving the slides forward.
Oh, okay, so now I think you went, okay, here it is.
So now you're at, wonderful. Thank you so much, and thank you everybody for your patience.
The second was an inpatient unit. These were persons with severe mental illness. It was a specially designed Latino unit, but it was sitting within a hospital which had all its own rules about, how an inpatient unit should be operated. And its goals were the goals of any inpatient unit to reduce the length of stay, and to foster appropriate community supports. Now, what we observed is that the staff was all bilingual as well as bicultural. Fortunately, this unit was able to attract such a staff. It even had a peer counselor who was a professional Latino and Latina who ran a religion and spirituality group for the program. But I want to say the main lesson we learned from this program was that the unit really created a community-like setting for the inpatients, because they built on the Latino concept and value of familismo, and the unit tried to create that atmosphere with the nurses and the doctors and the community meetings that they had. They also modified treatment modalities such as psychoeducation to work for the Latino population. Next, please. The third program was for outpatients who are Chinese, and this was at the Hamilton Madison House, and the program we looked at was continuing day treatment. And here, again, we observed staff who were bilingual, bicultural. Many of them had been actually hired from Hong Kong. Peter Yee really believes strongly in having a culturally based staff. And, of course, they played a major role in establishing trust with the people in the program, respecting their traditional social roles, their ideas about age and gender, which are so important to them, and involving the family when they could, but more than just one member of the family, because they work within extended families, bringing them in, talking to them about medication because they had compliance, because the Asian group had their own ideas about it, and a lot of work on stigma and shame reduction with psychoeducation. Next slide, please. So what did we see across these three programs that were common? There was a lot, and I've grouped them here by engagement and family community involvement, just for you to get a big picture of what we saw. But engagement was achieved by having culturally friendly milieus, by using either language of the persons, or some persons speak English, like the kids in the PASS program. So while language accommodation such as translation is not that important, communicating in a way that is acceptable to these youths was important, and that was worked on quite a bit. And all the staff were either bilingual, bicultural, and fortunately in these environments they were passionate and compassionate, which really helped the programs. There were very conscious efforts at trust building and stigma reduction, and each of the environments tried to modify services, some of which were EBPs, but modify them for the groups and to deliver them, because they were modified, in flexible ways, not so rigidly constrained the requirements of an EBP. And another major thing was that family and community were involved very heavily. Peers were involved, I'm including that under community, peers from the cultural groups that were in the programs, and strong outreach to families, which was extended families as well as developed families, and community involvement such as with preachers, pastors, and so on. Next, please.
We wanted to take a second there and just check in with everybody as to whether these elements are infused in your program. So please go ahead and keep chatting in. We've had a few folks that have already chatted in, so thank you for taking the time to do that and letting us know how you're approaching the role of cultural competence in your program. So essentially, many folks are kind of saying what you just said, Carol, where they're involving members, peers. Others are talking about policies and principles relevant to hiring culturally similar or alike individuals to provide the services, make sure that they have enough providers that speak the consumer language as well, providing literature in a variety of different languages. There's others who make sure that the explanation of services, there's a number of folks, it seems like the theme from the feedback that we've gotten so far is that information is provided in their own language, materials are provided in their own language. We try to have providers who match and understand the culture of the consumers that are coming to the organizations. Somebody did highlight, though, that whether, I think that some of the language that was used earlier was whether we infuse sort of these principles throughout the organization. Somebody highlighted, well, I'm not sure it's being infused throughout the organization, but at least on our program level, we do make an effort to be culturally competent. So that's also an interesting point to how programs may be doing some things, but whether as an organization, some of those principles are included. Others have also said that they are also using peers as well. Carol, I'm not sure if you have any additional feedback or suggestions for folks.
I just wanted to comment that, you know, I know that in cultural competency, most work has been done around language accessibility, where persons in the programs do not speak the languages of either the caregivers or the mainstream group. But you know, communication is really the root here, because lots of people who speak English are unable to successfully communicate with their caregivers. So cultural competency also involves that kind of not interpreting or whatever, but understanding the way people present and communicate is very critical. That's
wonderful. Thank you so much.
Okay, next slide, please. So, so now we sort of, from the 3-site study, had an idea of what the items might look like for an instrument. So we called together several stakeholder work group committee meetings to review the items, decide how we should scale them, and as researchers, we had criteria of reliability, feasibility of collecting data, and so on. And with these stakeholder groups, we did select 14 items scored on an increasing level of achievement, and you're going to hear more about that in a moment. Next slide, please. So just to end my presentation, why do an assessment? I think the bottom line is it is a roadmap. It's a roadmap to how to achieve cultural competency. We deliberately picked our items to give you a roadmap, and also the way we scale it talks to how you can move forward, starting from some of the simple stuff and moving to the more complicated stuff. So by using it, you can look at the strengths and assets of your program and then decide where you need to improve it, which allows you to create an action plan. And it can be used in training as a training tool as well. Okay, so now why don't you put up the scale, Lydia, and Jennifer is going to take over.
Hi, how are you doing? Thank you for having us present. It's a wonderful opportunity. So, Lydia, if you don't mind, would you just click through a few pages in? I want participants to get an idea on how the scale is laid out. If you stop here for a second, this is like one criterion. It lists what it is and a rationale along with the measures and some definitions and examples. So what I'm going to do is go through a few of them and talk about some of the measures and provide examples on how you can achieve this. So if you can go to the next slide, please, Lydia. Oh, wait, there was a chat question.
Yeah, so we wanted to just gauge, so kind of where everybody is, and have you utilized any assessments to evaluate cultural competency within your program? So are any of you out there already utilizing assessments, or are you using this assessment, the one that we're talking about today, or maybe you haven't even kind of considered it? So please chat in, just take a few seconds to chat in and let us know, are you currently using any assessments, and if so, which ones? And if you're not using any assessments have you considered in doing that, as we're kind of preparing to talk to you about one in particular. So if you can use that chat box, thank you. We have pretty good activity on the chat box, so thank you so much. So many of you are saying no, not yet. Others are saying yes, but not as detailed as this. So it seems like there's a mix of people who haven't really utilized assessments or haven't considered them, others that are, but maybe in a more general a way, not as specific and detailed as this one is, especially to the programmatic level. Wonderful. Thank you so much, everyone, for chatting in.
Okay, great.
So Jennifer, should I move on, or did you want to give some feedback?
I'm reading the responses. And it seems like some people do use some of those, but I'm not, it's a lot there.
Yeah. And somebody just chatted in, just so that you know, I should have said this at the beginning, the webinar recording and the slides and access to the assessment that we're going to cover will be posted on ctacny.com. We'll also have a link to the Cultural Competency Center, so you can also see the additional resources that they have available to you, as well as the other handouts. I know that was a question.
Okay, great. So what you have here are the actual 14 criteria that make up the assessment that we're showcasing today. Each criteria feeds into 4 domains: engagement, family community involvement, outcomes, and access. If you recall earlier, Carol presented a slide that highlighted the common elements of cultural responsiveness that were gleaned from the 3-site study. So those elements fed into engagement and family community involvement domains. However, when we developed the scale, we modeled it after the organizational scale, which was psychometrically tested, and added the additional domains of outcomes and access. So I'll be reviewing several of the criteria, as I mentioned earlier, from each domain and provide examples on how to achieve this. Next slide, please. So criterion 1. We have here cultural assessment of consumer. So it's a detailed cultural assessment in addition to age, gender, race, and ethnicity. I just wanted to mention that I'll only be reviewing those that are in bold. And the rationale is it provides a view of beliefs, values, worldviews of the consumer that can improve the therapeutic alliance and diagnosing as well. So the measure that I'm highlighting asks whether the program appraises level of acculturation or a person's cultural group identity, such as refugee or sexual orientation. So knowing this information can allow for review of disparities in service use most effectively. And then we have here criterion 1, which I'm not going to review. Next slide, please. So we have here engagement and communication styles. So all levels of the program staff communicate with persons from cultural groups in ways that are respectful to them. The rationale being that if communication is respectful, acceptable, and familiar to the consumer, that barriers will be reduced. So the measure there asks whether the program collects acceptable or unacceptable communication styles of the cultural groups. Carol earlier highlighted communication, and obviously it's not just verbal, physical, shaking hands when you greet someone, things of that nature. So the best source of information about communicating styles of the different cultural groups are themselves. Ask them. We have here criterion 4, which also builds on engagement, trust building. There's a measure here that asks whether the program has a designated staff member who explains HIPAA and assures confidentiality. So some groups may be hesitant to share information due to immigration status. If steps are taken to assure people that their information is held in confidence, it may alleviate some distrust. Next slide, please. We have criterion 5, engagement, culturally framed stigma reduction. And so the program intentionally conducts activities to reduce stigma of mental illness. The rationale being that stigma can impede engagement in services. And sometimes these groups delay seeking treatment or drop out of services because of the group's views of mental illness. A strategy for reducing stigma of mental illness is to discuss the values of their cultural group. You can then create activities to reduce stigma, perhaps making groups or networks that have a similar interest or cultural backgrounds, which may allow for exposure to others suffering from mental illness and create support networks with people from their own culture. Criterion 6, which I'm not going to review. Next slide, please. So we have criterion 7, culturally modified or new services. There's a measure that asks whether the program allows staff to flexibly deliver services to accommodate the cultural groups it serves. A way to modify a program is to incorporate cultural healers into conventional practices to increase the effectiveness of treatment for these groups. Criterion 8, inclusion in program of staff from cultural groups who have mental health experiences. So you have both paid and volunteers who have mental health experience and are from the cultural groups served by the program are included. There's a measure that asks whether the program staff receives training on working with peers from cultural groups. We're moving into a brave new world where peer services will be Medicaid reimbursable. Are your staff trained to incorporate them into the program competently? Using the scale will allow you to look at that and see if you're doing that. Next slide. I'm not going to go through criteria 9 and 10, but here they're listed again with what it's trying to measure and the rationale. Next slide. Criterion 11, satisfaction with program. So the program conducts activities to measure consumer and family member satisfaction with the services provided. The rationale being improvement for cultural groups needs to be based on consumer and family member appraisals of the program. So here we have a measure that asks whether satisfaction surveys routinely collect, the surveys can routinely collected by the program include information on race, ethnicity, LGBT status. Adding specific, culture-specific satisfaction questions can help a program make modifications to their services and improve engagement. Next slide. We have criterion 13, recovery outcomes, which examines disparities in service process outcomes and identifies and monitors recovery outcomes that are desired by the consumers from cultural groups. Now that's key, that they're desired by the consumers from the cultural groups. Your cultural background will color what you understand to be recovery. For some, it may be symptom reduction. But for others, it may be about being able to participate in family activities. And that's just one example. So there's a measure there that asks, does the program identify recovery outcomes desired by members of the cultural group? And on this slide as well, we have criterion 14, program outreach. So cultural groups are identified in cultural groups identified in the community service area who underutilize services and who might benefit from the program. The rationale being increasing enrollment for cultural groups into programs that might be a benefit to them. So outreach efforts need to be undertaken that include identifying these groups and informing them about what the program can offer. To reach folks in the community, plain advertising is really not sufficient. So has your program taken steps to identify key informants in the community service area? That's one of the measures specifically asks that. Next slide, please. So in summary, the program level cultural competency assessment scale, as Carol earlier mentioned, it provides a roadmap for an action plan. It should be used flexibly and should be repeated over time because what this scale can do is provide you with a baseline of where you're at, and but it's important to continue to reassess because the groups you see today will not necessarily be the groups that you see tomorrow. And ultimately, doing these assessments leads to quality improvement. So as we move to a value-based system, it's incumbent upon us to improve services for the people we serve, specifically those who are who have underutilized these services. And really, those are the groups that healthcare reform is really trying to make an effort to bring into services. I think that's it. Next slide, please.
Sure. So, Jennifer, I just wanted to, you covered quite a bit of content based on the assessment, and I think some really important domains in which programs can hone in on to try to identify how well they are applying some of those concepts. Do you or Carol have any recommendations for next steps in utilizing the assessment, or how have other organizations used the assessment to build these principles into their programs?
So at this time, we are looking to partner with programs because we're really at a rollout stage for this instrument. And I mean, what we hope to do, which we did for the organizational level scale, was that we tested the psychometric properties. So if we're able to do that as well with the program level scale, it would be great. So if anyone's interested in partnering, please feel free to contact us. And we would look to do that. It's in the public domain. We have it on our website, so anyone could actually access it and take it and use it. And I want to stress, you know, many people say that time is an issue. So what you can do with the scale, I had laid out these 4 domains about engagement, access, outcomes, and family community involvement. If you want to focus on a specific domain, you can do that as well. If again, time is such a critical issue.
Yeah, let me re-emphasize that we know that we have gotten some interest in parts of the scale, particularly engagement. I think engagement is one of the major
yes.
facets of healthcare reform. You know, we want to make sure that people who should be receiving services are getting services and are, you know, in appropriate programs. And, you know, we have documented disparities of early dropouts, you know, unequal access rates, early dropouts, people not being properly retained in their programs. So I think the access, if you know, I think you were asking, Lydia, where might one begin? I think that the access measures, the engagement measures speak very directly to some of the goals of the models that are being rolled out. So we've been even thinking of packaging some of that as a separate, like, engagement measurement tool, because there's been some interest with some of the DSRIP providers about doing that. So that's one direction we might take. But we are very anxious to partner with groups that might want to use it to help understand, you know, if it's really working properly, and particularly the psychometrics. We'd like to show that it does, you know, better program-level cultural competency does predict better outcomes. That is our goal. We sort of have evidence of that for the organizational-based instrument, and in fact, it enabled us to hone in on certain of the items that were more predictive than the others. So that's our next phase with this instrument, but I would reiterate that it is in a rollout phase, in a testing phase, and so on.
I wanted to take the opportunity to respond to two questions that I saw in the chat. So the PCCAS, it stands for Program Level Cultural Competency Assessment Scale. We didn't put the L, but we used PCCAS. So that's one question. And the other question that I see here, it has to do with what appears to be a lack of mention of white ethnic groups. So when you do this assessment scale, we're not telling you what groups to identify. The cultural assessment, criterion 1, speaks to obtaining information about whoever it is that you're serving. So if your population is, let's say, Russian immigrants or German, whatever the population, you should be able to do that. Again, we don't tell you what the groups are that you should focus on. If you're doing the assessment, you'll see who it is that's coming into your door.
That's really helpful, and I think the idea being is that the assessment is a broad assessment, right? So it's not specific to certain groups, but more about how within programs are we identifying who we work with, making sure that the services align with what the needs and sort of cultural understanding and beliefs are of the people that we serve, and in each of the different areas in which we provide services. So I think that's really helpful. Thank you for doing that. We did want to ask folks before we move on and take some additional questions. So make sure we do have some time to take some questions. So feel free to use that chat box and submit your questions for the presenters on whatever aspect of which they've presented today. But I did want to take a moment to also hear from you as to which domain can you start focusing on right away to begin incorporating some of these principles within your programs. And maybe it's just, you know, downloading the assessment and looking at it and seeing if you can apply it. Maybe it's having a staff meeting to even just talk about it in a more sort of focused and concerted way. So what is one thing as you're kind of listening through this webinar, and especially if you also attended the first one from the Center on Organizational Cultural Competence, what are some things that you think you can start doing to continue this discussion within your programs? So we have some folks that are chatting in to listen to clients and new about cultural areas that they are bringing to therapy sessions. So basically communicating with clients, which I think was an important point that the presenters said. Some folks are thinking about downloading the assessment, incorporating it into other types of programs, everything from independent living to outpatient programs. Focusing on engagement. Carol, that definitely sounds like it resonates with folks as they're typing in. Others are really thinking through how to utilize some peers in this process. I know we, as part of CTAC, have had this conversation on an ongoing basis around how to incorporate peers a little bit more and what are some processes there. So I'm glad that the assessment and some of your recommendations also attend to that.
Let me just comment on that. We're very keen on incorporating peers into programs because that's one of the best ways to begin the trust building, you know, by communicating with like persons who have experienced services, who are in recovery. That, you know, it's a strong way to build trust. And also, if you have peers from the cultural groups, they can really help others on the clinical teams understand the cultural nuances that could impact the way services are delivered, because they know how these groups communicate, they know their value systems, and so on. So the engagement of peers, we think, is very critical.
So if people want more information about the scale or access to scale, you can feel free to download it from our website. You'll see a slide later on that has some contact information for our center. I just wanted to mention that I did not include him, but Gary Hoagland was also one of the authors in this instrument. So I just wanted to mention that.
Yeah, thank you so much. I just pulled up the slide. So the center's the center's website address is cecc.rfmh.org. You can also access this webinar recording, the slides, and we'll also have a link to the handout as well as a link to the center's website on ctacny.com. And I think there was also somebody asking about accessing the information from our first webinar from a couple weeks ago, and that is posted on ctacny.com as well. We have a number of folks that have continued to chat in, so thank you so much. And we have some folks that said that they're also for example, part of that DSRIP process around cultural competence. So I'm glad, thank you for being at the table and for listening to this, and that the mention there is that that assessment will also be helpful in thinking through how to implement and incorporate some of that process. That's really wonderful. I do want to just highlight that if there's any additional questions or comments for the presenters, to please go ahead and submit those. We do have a couple of minutes before we have to wrap up. As you're sending in some of your questions, I just want to highlight again how to access the CEU. So this is for social workers in particular. The NYU Silver School of Social Work has partners with us to be able to give you 1 CEU credit for attending today's webinar. You'll get an email within the next day with a link that will take you to a CEU processing page where you'll be able to register. There is a small $15 processing fee required through the school to process the CEU. You'll have to complete a brief knowledge test, and then you'll be able to get your certificate within 10 business days. So all that information will be sent out to you again within about a day or so to make sure you have that information available to you for those that are interested. So please feel free again to submit any additional questions. Jennifer or Carol, do you have any additional comments based on a lot of the chat that's coming in on sort of next steps and recommendations for implementation of some of these concepts?
I just wanted to reiterate, sort of bring in the beginning to the end now, which is that we view cultural competency as a system-wide intervention, and it's not just about giving a caregivers cultural competency training. It's really about infusing on the different levels of a system things that could go on, whether it's policies or hiring practices or whatever, things that have to go on to make sure that it trickles down from the organizational level to the program level to the clinical staff and back and to the consumers. So there's a chain of things that have to go on. And what we've presented here today really emphasizes what goes on in the trenches when you're trying to deliver a program and ways to make that program a little more culturally responsive to the clients. And it could be, as Jennifer said, we're not just thinking about racial, ethnic groups. We're thinking about cultural groups in general. I don't know if we have any upstate providers on the phones, but we know that in some areas there are not that large percentages of blacks or Latinos, but there are refugee immigrant groups. Even rural populations have their own cultural needs. So I think that's how I want to just pull it back to the beginning again to close it.
Great, wonderful. Thank you so much. And I think that's a really important comment. So feel free to keep submitting any questions that you have in that chat box. I will take the time to sort of mention, so this today wraps up our webinar series on cultural competence. Thank you so much to Carol and her team for presenting on both of those webinars. We do have another Lunch and Learn webinar through CTAC, which is going to focus on race and trauma, race-based traumatic stress and psychological injury by Dr. Carter, May 28th, 12 to 1:30. So make sure to check your email announcements from CTAC for a registration link for that upcoming webinar for those that are interested. That one doesn't have a CEU tied to it, but we do think it's an important and helpful topic. I just want to highlight that that there are a couple other comments. So, folks are also talking about incorporating cultural competence for a variety of different reasons and different types of programs, everything from residential, independent living to health homes. And also others have said that, they really think it's important to look at this, especially to your point, Carol, as folks are transitioning to managed care in many aspects to ensure that that's a big part of the process. So it sounds like this has been a helpful webinar for folks. Again, the webinar recording, slides, and the tool will be on CTAC.NY.com. You can also go directly to cecc.rfmh.org to access the center's a vast array of information that they have available to providers. This is our email, so Carol and Lenora, who was on our first webinar, and Jennifer's email, so feel free to reach them directly with any additional questions. For CTAC, please feel free to reach me at lydia.franco@nyu.edu, or you can go to ctac.info at nyu.edu. So if there aren't any additional questions, I think we can wrap up for today. I actually think that there is one question. Carol, I'm not sure if this is something you'll be able to answer, specific to health homes and incorporation around use of peer services.
That's more to someone who's more involved with the way peers are going to be paid for. It should answer rather than me. I hope they get decent salaries. That's my point.
Yes, I think we all agree with that. Thank you so much, everybody, for taking the time to be with us today. Again, you'll receive an email with information on accessing the CEU credit, as well as going to ctacny.com for additional information. Thank you to Jennifer and Carol and the rest of the team at the center, and have a wonderful day to everybody.
Thank you all for listening. Thank you.
Bye-bye.
Bye.